Okay, I did it. It works. Hopefully you guys can see my slides. If not, give me a little like hoot and a holler. Um, and hopefully my video is not wonky. The other day it was freezing and wonky because my slides were so big. Okay. Hello, everyone. Welcome. My name is Kira. I'm joined by Dr. Jones and Jennifer. We have our little, actually, I guess I don't have my name tag, but it's up here somewhere. Um, you guys can look for that. We are pre-health shadowing. Thank you guys for joining us. I'm excited for this shadowing for tonight. It's going to be about an hour and a half, so hopefully you guys all planned that out well. We are an international student-led nonprofit for medical advancement, and we have people from all over the world, so we're a very diverse little group, a little bubble. We do have closed captioning that is provided by Zoom, so sometimes that is not all that great, but AI is improving, and I was actually very thrilled with the level of captions that even YouTube started having because I love captions and I frequently noticed a lot of errors. But if you have any ideas on how we could be more accessible, or any ideas on how we can make things better for you or any of your abilities, let us know. You can email us at info@prehealthshadowing.com. And while you're doing that, maybe add us as a contact so we don't go to your spam, because I always hate spam. And you can also join our email list that way as well. If you want to stay further in our loop, we have a variety of little social medias over here, including YouTube, which it's not really social media, but it's kind of social media. I don't really know. I'm not a big YouTuber. And you can sign up for our email list, as I mentioned before, but keep it going. So I always love to see where everyone's from. I'm from Los Angeles, California, and you guys can post it in the chat. If I could even find the chat, it's kind of just thrown up there somewhere, but or maybe no one's chat savvy and they're just not gonna say anything. New Jersey! Jennifer, also Los Angeles. Los Angeles buddies. Wisconsin. I just came back from there. I went to the Cheese Castle. It was great. Idaho. Illinois. New Jersey. That's a few New Jersey people. Virginia, Atlanta, Georgia, DC. Okay, I'm closing. We're moving on. I'm excited for the session. I'm sorry if I missed you. If you're interested in being part of our team or our volunteers, there are two different places that you can go. Volunteers are less time commitment. If you want to be wishy-washy, flexible with your schedule, perfect. Be a volunteer. It's 100% remote. You get to pick your schedule and your projects and whatever department you want to volunteer in. If you want to go into the marketing department, come over here. We'd love to have you. If you want to be in other departments as well, you can even volunteer in multiple different departments and see where you place or where you go or what you're excited about. I always tell people that even if you want to be on the team, you should volunteer for a little bit and see where you go. If you want to join our leadership team, that is a bit more commitment. Most of our positions have a minimum of 5 hours a week, and they go up to the 20 hours. It depends on the position that you want. If you want to join that, I will send that link because I don't have anyone sending links right now. But if you want to join that, it is just prehealthshadowing.com/join-our-team. And you can go and see the positions that we have available, as well as the time commitments for those, what you'll be doing, what you're required to do. And so there's a plethora of different roles. They're all listed right here. And if you see at the end, it says and more. If you notice that there's something that you would like to do that's not a part of any of these roles, you can always make your own little role, or see if there's any position that you can fit into. So I know that diversity and inclusion needs a lot of people, but maybe there's not a spot that you necessarily want to do in that, but you notice that there's a gap in that department. You can always make your own role. I always love making roles. So if you want to do that, there's a link at the bottom. It's just join our team, which is pretty easy to maybe memorize, hopefully. If you guys are pre-health students, your memories are probably great. If you're a high school student, we do get those from time to time. We have actually a lot of high school volunteers, which I'm excited about. We do have the HTP, the High School Training Program. It is a chapter or organization creation program, and all of the information is on our website. If you go to the Get Involved link or tab, you can also just go to prehealthshadowing.com/HTP, and that will also pop it up as well. And you can learn about how you can start a chapter or a group on your campus, which I always think is amazing. If you know what you want to do in high school, props to you, especially medicine. If you can donate, our program is completely free. All of our courses, all of our information, everything that's pretty much given to you is solely based on our partnerships, our time, and the no donations that we get. So if you can't donate money, you could donate time and be a volunteer. But if you can't do that, you can always pass around our link. It's just prehealthshadowing.com/donate. And you can help us out even a few dollars or $5 or whatever you want to muster up. I don't think you can donate change, but someone can try. But yeah, if you can, I'm more than welcome to accept that. Type any of your questions in the chat. We will have a Q&A toward the end, or maybe Dr. Jones will, decide that she wants to answer questions willy-nilly. That's up to her. But we do have a time for questions and answers at the end. And we do have someone that's going to be marking those down. So don't worry if your question gets mixed up in all the flurry of the comments. Wink, wink, comment, lots of comments. So take good notes as well. We are going to have a quiz after this. That quiz will not be on Zoom. I will explain how the quiz works at the end of this session. If you've been here before, you probably know exactly where that goes. And I'll tell you how you get your digital certificate and you can verify your hours that way as well. So last little thing, if you can put your cameras on, I always love seeing faces and not just my face sitting up here. But I mean, at least I have Dr. Jones and Jennifer, but your faces, not just a turtle eating pizza. But maybe the turtle eating pizza will talk and we'll see the turtle eating pizza on the recording. Who knows? Well, without further ado, thank you, Dr. Jones, for joining us, and I'm excited to hear what you have to say.
Awesome. Thank you so much. Okay, so I am going to share my screen. Is that correct?
Yes, that would be
Let
love.
me do that. And here's my screen, share, and then I'm going to show you the backstage of my Canva. And then I may go into present mode. Okay, let's see if there is a way for me to see the chat while I do this. I'm going to go flip back and forth, I guess, so that I can see. I'm going to try, I think, after every slide, maybe. What did I just do? There it is. After every slide, I'll check the chat and answer any questions that anybody has. Um, so I'm tickled that y'all are here today. My name is Ellen Jones. I am a pharmacist. So I'm going to talk to you today about my job as a pharmacist and then also pharmacy academia and just kind of what I do. So let's get started. One, what is pharmacy? And this is just a standard, you know, definition. So, pharmacy is the health science that focuses on the discovery, development, preparation, dispensing, and proper use of medications. It bridges biology and chemistry, ensuring drugs are safe, effective, and used appropriately to improve patient health. Second bullet point, pharmacy also involves patient care, where pharmacists use their expertise to educate patients about medications, manage therapy, and work alongside doctors, nurses, and other health professionals to promote optimal health outcomes. So those are the dictionary definitions of pharmacy. The short answer is I am the medication expert on the healthcare team. So it is my job to understand all the medications, what they do, why they work, who they work for, and I help with medication selection. I do a lot of things actually in my role as a pharmacist, but that's kind of the general idea. What will happen if I do this? Are y'all seeing, what do y'all see when I do this? Are you still seeing my screen?
We see your whole screen and your Canva background.
Okay. Well, if in the chat, or how about to Kira, if you want to just keep an eye on the chat and feel free to interrupt me if you see something cool. And I actually really enjoy being interrupted. So I love to answer questions. So let's just do this again.
That works. I'm a great interjector.
Perfect. Because I can see some of your names over here, like as the users, but I can't see the chat. So I will trust Kira to keep an eye on the chat. I'm curious if y'all can just pop in with what sort of healthcare y'all are interested in. Like what pre-health science are you? We can get a little data.
Is it cardiology? I'm a
Mm,
psychiatry, neuroscience,
okay.
pre-PA, anesthesiology again, pathology. I love pathology. Oncology, also love oncology. Gynecology,
Love
internal
it.
medicine.
So, several of those that you all have mentioned, you can actually specialize as a pharmacist in those disciplines. So, I'm not sure what all y'all have learned about pharmacy, but you can do a residency as a pharmacist. You can practice directly after graduating with your PharmD, but now many pharmacists will choose to do a PGY1, which would be like the intern year, sort of for MDs and DOs. And it's kind of just a broad year. You have a year of rotations where you get to see internal med, CCU, family med, that sort of thing. And then you can choose to do a second year if you want to specialize even further. So right now we have PGY2s in critical care, emergency medicine, um, oncology, psych. There's a few other ones. Community pharmacy or ambulatory care pharmacy is another PGY2 you can do. So there's a lot that's actually growing in pharmacy, and we always work really closely with the entire medical team, the MDs and the DOs as the med experts, and it's a lot of fun. Actually, I really enjoy that. So let's do this. Yeah. So, like I said a second ago, these are some of the different places and areas where you can practice as a pharmacist. So, community pharmacy, that's what you'd think of with your typical retail pharmacy space. There's actually a few different ways to do that. We have your chain pharmacies, the larger big box stores, your Walgreens, CVS. Grocery store chains, but there's also independent pharmacies in Arkansas where I live. It's a very strong independent pharmacy state. So, like in my White County, Arkansas, there's 20,000 people that live in my town, but there are 8 independent pharmacies, and it's a really great way to practice. You get to know your patients a little better. Anyway, there's a lot of opportunities there. And I would say the majority of pharmacists would go into community pharmacy. But then we also have inpatient pharmacy, that's your hospital pharmacy or health system pharmacy, where you can work in the operations, where you're spending most of your time verifying orders, um, using protocol orders, making the IVs, verifying just making sure the right meds are put into the Pyxis or the Omnicell for dispensing from the nurses. So that's a big job that a lot of people do. But then there's also the more clinical side. Clinical is kind of a tricky word when it comes to pharmacy, where we all learn how to be clinical pharmacists, but some people have the actual title of clinical pharmacist, which really means that they're making the clinical decisions for the patients. And so there are some disease states that pharmacists diagnose. We don't do a lot of diagnosing, but in Arkansas, for example, community pharmacists are allowed to diagnose flu, strep, and COVID, like test to treat is what we call that. So in the community pharmacy, we can do a COVID swab, a strep test, and then we're authorized to prescribe the appropriate treatment for those. We can also prescribe birth control and smoking cessation. Um, Also, you can prescribe HIV, PEP, and PrEP. So an expanded opportunities for pharmacists to have more clinical roles in the community. But your typical inpatient pharmacy clinical, they're usually going to be decentralized. So, like if they're a critical care pharmacist, their office or their desk is in the unit, right? So they're there with the team full time, rounding with the team, and making those clinical decisions. They're working the patients up just like you would as a physician, making those clinical decisions, putting the orders in. When I was a resident on critical care, I would make the recommendation and then I would also be the one that entered the order just because I had my computer there. So we're fully embedded into the healthcare team for sure. We just spend a lot more time focusing on the medications and when and where they're appropriate, different dosings, renal dosing, dose adjustments, things like that. Ambulatory care pharmacy, I'll be real honest. I was a pharmacist before I even really understood what that meant. Like I knew, but I didn't. And so now I actually work as an ambulatory care pharmacist. So what it doesn't have anything to do with ambulances, which some people think, but it's ambulatory care means the patients can walk in and out. So any outpatient clinic would be considered ambulatory care. So outpatient oncology is a type of ambulatory care. Outpatient psych, primary care, the office where I practice is a primary care clinic. So those are all considered ambulatory care. That's a pretty quickly growing aspect of pharmacy as well. Long-term care pharmacy, that's your nursing homes. A lot of pharmacy work with that is not as much about the dispensing, but it's more contracting. So those could be considered consultant pharmacists, where they're contracted with payers or with nursing homes to do chart reviews for all of the residents there, looking for appropriate medications. So that's a big focus on geriatrics. A big component of geriatrics is deprescribing. You get a lot of really long med lists in a nursing home. And one of the roles that we have is to stop those inappropriate medications because the older you get, the more severe some of the side effects can be. And something that was helpful before has created new problems now. And so it's important to keep an eye on those. A home infusion pharmacy, that's a compounding, we do sterile compounding for those IV meds that the patient might get at home. Compounding pharmacy, there's sterile compounding, and there's also non-sterile. So non-sterile compounding is a lot of patient-specific stuff. We create dosage forms, for example, or specific doses. We had a patient who's on testosterone, for example. He was on testosterone, but he had a reaction to the carrier oil that the testosterone was in. And so we had to go to a compounding pharmacy to have that compounded in a different carrier oil that he didn't react to. So lots of problem solving when it comes to compounding pharmacy. Then we have pharmacists that work in the industry. They work for the drug companies in research and development during clinical trials. There's a lot of times, anytime there's a clinical trial, there's going to be a pharmacist who is unblinded, who is the one dispensing those medication or knowing who's getting what, making sure the dispensing is correct. And then all of those placebos that are part of a placebo-controlled trial, a compounding pharmacy is going to create those. So there's a whole world of that. Then in the industry, you have MSLs, and those are the disease state experts that work for the drug companies to where, you've got drug reps that are calling on clinics and calling on physicians to educate about a specific drug. The medical science liaison is the one who is allowed to talk about the disease state. They are the trained expert. Physicians can do this role as well, but there are pharmacists in these roles. You can work in academia as a teacher, or a lot of times researchers can work in academia as well. That is my job. I work for a college of pharmacy. I'm an associate professor. So that is part of my role. I'll talk more about that in a second. Then we have government and regulatory working in in different legal aspects. We also have pharmacists who work for payers. So our third party payers, Medicare, Medicaid, commercial insurances like Blue Cross Blue Shield, et cetera, um, where they're the ones when you have the individuals that are reviewing those applications and verifying those. Working in public health, that's a great job. That's kind of a government job as well. Doing research, anybody can do research. You can be working in a hospital and do research. I do research in academia. Nuclear pharmacy. So if you think about people who are getting any sort of scans, like gallbladder scans, CTs with contrast, those have to be prepared by someone. And it's a nuclear pharmacist that prepares those medications. And then vet pharmacists, there's a huge industry now of vet pharmacy because everybody has a dog and everybody needs medical help with their dog. So it's a growing. And then military pharmacy, right? So you can be medics. Every military base has to have a pharmacist, things like that. So anyway, tons of tons of different ways to do a pharmacist. It is so much more than dispensing. Now, dispensing is a big part of what we do, but there's so many more ways. Sky's the limit. Okay. Kira, stop me if anybody has any burning questions.
Will do.
Okay. For now, let's go to the next slide. So this is me, how I got here as a pharmacist. So I actually started out, I was a music and theater major. Um, I was going to be a chemistry major to start with. My daddy is a pharmacist. He's a retired pharmacist. And I thought about doing that, and then I got a voice scholarship and thought, well, that will be fun. Let me do that instead, which is what I did. And I loved it. It actually worked out really well. I met my husband. He was a theater major, and we got married in undergrad. I graduated, then I worked in theater for a couple of years. I lived overseas. I lived in Italy for a couple of years. Then we moved back to Arkansas, I grew up in Arkansas. Moved back to Arkansas, and I was a stay-at-home mom. I had two daughters who had just started school when we moved back to Arkansas, and I was like, um, pharmacy sounds cool again. I did not like staying home. I loved being a mom, but the stay-at-home part of mom was not for me. And so I was like, well, let me just give it a shot. I still needed 2 years of prereqs, right? I hadn't had a math class since I was a junior in high school. So I had to start back with college algebra, freshman chemistry, all these same courses that you all are taking. And I was like, well, and if I don't like it, then I'll go work at a bank or whatever, and that will be fine. But I got into school and I loved it. And so I completed my 2 years of prereqs and started pharmacy school in 2012, graduated in 2016, did my PGY1 resident in a small rural 300-bed health center in Batesville, Arkansas. And then the year after my residency, I actually, if you think about it from tax purposes, I got 7 W-2s that year. So I worked at an oncology clinic, compounding as an oncology pharmacist. I didn't specialize in it. I was not on the treatment side of things at all. I was more on the dosing and compounding. So it's hazardous compounding, which is a kind of a specialty kind of thing. So I did that. Worked PRN for some community pharmacies, which was a lot of fun. And then I started to work at a long-term advanced care hospital, which is for insurance purposes. Usually there's a limit to the amount of time someone can stay inpatient in the hospital, but sometimes the patient needs more care than that. So, like, for example, people who are going to be on 6 weeks of IV antibiotics, or someone who they have not been able to wean them off the vent. They're intubated and they're just not healthy enough to extubate. And so it's people who are really sick, who need a lot of level of care. But I started working for them in 2016. 17, and I've continued to work for them on the weekends. So that's kind of how I stay up on my hospital patient management. And then in 2018, I started as an assistant professor of pharmacy practice at Harding University in Searcy, Arkansas. It is a small school, a small Christian school, liberal arts university, but we do have a pretty large health sciences department now. We have a pharmacy school, we have PA school, PT, occupational therapy, communication science and disorder. It's the number one nursing school in the state. Um, we just started a CFIT program, which is cardiac function. So it was the first one in the nation for cardiac function. Those are the people who go in and kind of help map the heart, who are working with kind of interventional cardiology. So that's a pretty cool program as well. So we have a very strong health science presence. This is a photo of me at the Arkansas Pharmacists Association meeting this past summer. And then Dr. Carter is one of my colleagues, and then that's two students there. So that's just kind of us. And I love my job. I love my job. I don't know if I talk about this, but I coordinate 4 courses at Harding. We have something called Patient-Centered Care Series. It's an 8-course series throughout the didactic curriculum where we learn the top 300 drugs. So because we're the medication experts, you you do not leave my classroom until you know the brand, generic, class, indication, mechanism of action, counseling points for the top 300 drugs. Now, there's way more drugs than that we continue to learn, but pharmacists have to be fluent, right? There's 2 names for every drug, and we have to know both. So there's a lot of language learning when it comes to pharmacy. And we go pretty deep. We go into chemical structures and structure function relationships and receptors, and we go pretty deep into the meds. And I love it. It's pretty complicated, but it's also pretty awesome. Okay. Oh, something else that's unique about Harding is most pharmacy schools are 4-year programs. There are some that are accelerated for 3 years. Um, but Harding now does a 3.5-year program. So for our students, we learned during COVID when we had to pivot to online that many of the topics that we teach and that the courses, they actually worked really well online. And so what we were able to do is take those courses that made more sense online and pull those into the summers. And so that it kind of made the school year less intense from an hour standpoint, from an hours in class, and we could focus more on that pharmacotherapy, pharmacology of these disease states. And so our students actually start the summer before their fall online. They take 8 hours online, and then during the regular school year, it's regular on the ground classes. And then in the summers, and then they start their rotations that would be that 4th year in January. So we're about to send out another cohort for their rotations. You do 10 rotations in a year, and then our students graduate in December. So why would anyone want to be a pharmacist? Well, I'll tell you. Um, a little personal about myself. I am a smarty pants, and I really enjoy being the person who knows the answer to a question. And I have found that pharmacy is a fantastic role for me because I get to be a resource for my team. So, it is my favorite thing when I go to my clinic where I practice and they're like, "Oh, I'm so glad you're here. I have this question. Can you help me? Can you answer this question for me?" And I can because I'm trained to do that. And so I really love being a resource for my team. And another thing that we talk about in pharmacy school is critical thinking, which you all learn this in your pre-health sciences, and you'll learn this in your disciplines, but how to think critically about the information that we find. right? So not only do I know where to look for the answer, I know what to do with that answer. And that's what your training will give you as you pursue these medical careers. A lot of problem solving. Creativity is really important, thinking outside the box. We do follow our guidelines. Of course, we love our clinical guidelines to follow, but sometimes when it comes to individualizing that for a specific patient, it requires some creativity, and I really enjoy that. We do have a very strong foundation in science. I would say it's a great marriage of chemistry and biology. We tend to focus a little more on the chemistry of things, the pharmacokinetics, pharmacodynamics, things like that. But also, and this is true for all of you as well, we have to be excellent communicators because if you think about it, I have to be able to speak at an MD level, right, or a DO level with the guidelines and the science. I have to be able to speak that language fluently, but at the same time, I have to be able to effectively communicate with my patient with a fifth grade health literacy level. And being able to communicate on both of those levels is so valuable. And so that is something that I really enjoy about my job. And then, like I was talking about before, there's so many ways to be a pharmacist. And so there's a practice site for every personality. If you love to talk to strangers, I've got that. If you don't want to talk to anybody, you just want to put your earbuds in and make IVs, you can do that as well. And and then everything in between, like nuclear pharmacists, there's nobody else in the pharmacy. You don't see the patients, you don't see the prescribers. You're just in the hood making your stuff. So, and the cool thing about pharmacy is that when you graduate from pharmacy school, you're qualified for any of those roles. You don't have to specialize. You can choose any of those that you want. We do have a pretty well respected profession. Last I heard, well, maybe second now, that pharmacy is one of the most accessible healthcare professions, right? You just go in the pharmacy and they're standing right there. Now we're busy. We're very busy, but we're accessible, right? You can ask that quick question, and we have the knowledge to be able to provide those quick answers. It is built in to be a lifelong learner. As you know, medicine changes on the daily. There are new drugs that are brought to market daily. And you know, guidelines change, right? What we know now is not what we knew 5 years ago. And like, especially in diabetes, right? We get new guidelines very regularly, and we have to keep up with that. So we all, just like any healthcare profession, we have to have continuing education to keep those hours up and maintain our license. And then work-life balance and stability. There's pharmacy is a very solid profession. We're always going to need pharmacists. Um, and that work-life balance, I would say for most pharmacists is fantastic. Now, a lot of pharmacists work a lot of hours, but there's ways to craft your career, right, in such a way that you get that work-life balance. Some people love that 7 on, 7 off schedule. Some people love to work the overnights. There's, again, like I said, there's a job for every personality and every lifestyle. And then family life as well. It's very common to have, you don't have to give up a family to be a pharmacist. And so that's been very important to me. I already had children when I became a pharmacist. But a lot of people are having life, right, while they're having their careers, and that's okay. And then, of course, there's ways to have leadership and innovation opportunities. We have several national organizations that I'm actually a member of all of them because I'm a kind of a joiner. But we have the American Pharmacist Association, which is our large blanket organization, the American Society of Health System Pharmacists, ASHP. That is our hospital or health systems organization. We have ACCP, the American College of Clinical Pharmacists, and that one is a smaller organization, but it focuses more on the clinical roles that we have. We have NCPA, that's the National Community Pharmacist Association, which is for the community pharmacy. And then there are pharmacists out there really innovating, which I could talk about for a long time. There's people out there doing some really cool stuff, stepping outside of the box and innovating and using their entrepreneurship to improve patient care. So I don't know if you can tell, but I really love my job. Okay, next. Here, let's just talk about a day in my life. So let's see. So this is kind of an old picture. This is a picture of me at my clinic. My clinic is called One Life Direct Primary Care. So, direct primary care, you may or may not be familiar with, but it's a practice model where the physician um, does not bill insurance. So it is a membership based program, and it's growing because a lot of physicians. So the physician that I work with, his name is Joe Duggar at One Life. He's been a doctor for 30 years in my area, and he worked in a traditional clinic setting, and just I guess 3 years ago or so, he stepped out into DPC where patients pay a monthly membership and then they get 24/7 access to him um, and unlimited office visits. And so we manage a lot of our um, patient care over the phone or via text. Sometimes they're like, "Hey, I don't feel good." They'll text and he'll do some triage, and then he can make a decision there, like it's a telehealth, or he can say, "I really think you need to come in, and let's draw some labs. Let's get some images. Let me take a look at it. Let me listen to your chest," something like that, and really provide that personalized care without having to worry about the metrics. Our patients are scheduled for at least 30 minutes, most of the time an hour, which is pretty rare in most medical settings these days. They tend to be pretty jam-packed. So it is becoming more and more popular because a lot of the a lot of these practitioners are saying no thank you to the fee for service model. So and that's a whole nother conversation. So this is me with a couple of my students a couple years ago. They both went into independent community pharmacy. And then here, this image here, this is just a typical med list that I see, and it's a pretty junky med list, I'm going to be honest. Um, if if this were a new patient this is not actually one of my patients. If this patient had come to me, we would definitely have some conversations about some deprescribing. So something that pharmacists do a lot is something called medication reconciliation or MedRec. And the concept that everybody's supposed to be doing this. This is not a pharmacist specific task. This is something that nurses may be doing, like on admission. It's something the physician should be doing at every visit. And what that is making sure that every medication has a diagnosis, right? Why are you taking this medication? Is this appropriate? And then every diagnosis that the patient has a treatment. It may not be a med, but they may not be managing that particular thing with a medication, but reconciling that, making sure that we're asking about supplements, right? Because those have drug-drug interactions sometimes, and then confirming that the stuff that is on the med list is the stuff the patient is actually putting in their body. Because sometimes you get some labs back and something is off, and your first instinct is to add a med, change a dose, something like that. But the question you have to ask first is the patient taking what I think the patient is taking? Because sometimes the problem is adherence to their medication regimen more than it is what was prescribed. Now, there's lots of reasons a patient might not take something as it's prescribed. Maybe they can't afford it. Maybe it gave them a side effect they didn't like. Maybe the pill's too big. Maybe they have mobility issues. Maybe they can't remember. Tons of reasons. And it is part of my job to investigate that and resolve the issues that I can. This is a task that needs to happen every visit. It needs to happen anytime a patient is admitted, and then it needs to happen on discharge as well. There's a a big gap in how things are managed inpatient versus outpatient. And since I work in both, I see that. For example, a patient with diabetes, right? So a patient with diabetes, and let's say their kidney functions down, and so they're just on metformin, but their diabetes was not well controlled. So when they get admitted, they get started on an insulin protocol of some sort. They're holding their metformin because of their kidney function, or they're going to be getting imaging or something like that. So then on discharge, it's time to send them home. Well, let's just click everything that they were on and let's send prescriptions for that. And that's how you get a patient on inappropriate insulin treatment, because insulin would not be appropriate in the outpatient setting for every patient, but that's what we do in the hospital. There are new different oral medications that a lot of times they don't always start inpatient, because the person that's inpatient that's managing meds might think, well, that's an outpatient problem. They'll fix that at their follow-up. So there's a lot of communication that's very important between that during that transition of care. That's another pharmacist role. You can actually be a transition of care pharmacist, where that's your entire job is to do follow-ups with discharge. I forgot to mention that. So that is something that I do as part of my role. This image here is just a random, it's a Google image. This is not a patient specific thing of um, this is an iron panel, so maybe an anemia panel for a patient. And so our patients, when they get labs, we get our labs back the next day. And so one of my jobs is to look at all of the, look at their meds and see what's appropriate, make adjustments as needed, see if we need to come in and talk about something. Sometimes we can just send it, via text or telephone, but sometimes we need to start a new medication, and so we need to come in and educate and talk about that. This photo here, this is the classroom. So this is a photo of me. No, well, I'm not in the photo. This is a photo of my classroom. This was my P1s this fall, and this is where they were learning how to take manual blood pressure. So that is something that pharmacists do. That may be something you don't think about a pharmacist doing, but we absolutely can do that. There's actually a study that came out, side note, that pharmacists do a better job at managing hypertension than a lot of other areas. And there's a lot of aspects to that. Maybe it's the number of times we see those patients, stuff like that. But there's some pretty cool interventions that pharmacists can have a role in that can make a really big impact into our patients' health. This is a screenshot of a APHA webinar that I attended about entrepreneurship. So that it's just being involved in the organizations. This is I presented at the ACCP, that's the Clinical Pharmacy Annual Meeting a couple years ago. So I'm very involved in all the organizations. I I presented on the new AFib guidelines. I'm about to present on menopause here in a little bit. And then this was something that I just did recently for pharmacy students at the ACCP meeting. We do a session on how to prepare for residency and things like that. And so I did just a presentation on how to do good interviews for your residencies. So I teach classes, I see patients, I manage medications. So this is what I do every day. Next, so I just created this pretend case. This is not a real patient's gene site report. But one of the things that we do in my clinic is for any patient who's going to be on any mental health, we call it psych meds, but really any mental health medication, antidepressants, anxiety, mood stabilizers, ADHD, sleep. You can do genetic testing on these patients now because we have what's called drug gene interactions. You've heard of drug interactions, drug disease interactions, drug food interactions. You actually can have drug gene interactions. And so you've probably learned about some of these, but your genetics determine how your body body treats some of these drugs. And so some patients need a higher dose, some people need a lower dose, some people need to avoid certain medications altogether. And so what we do for our patients is we do a DNA test, and there are several out there, but the one that we do is a company called it's a product called GeneSight by a company called Myriad. And it's a cheek swab, just like you would expect, and then we send it off, and then 3 days later we get the report back, and it looks like this: green, yellow, and red. And so let's just say we have a patient, Michael. He comes in, 3 month history of worsening low mood, anhedonia, fatigue, impaired concentration. So that's saying depression, right? Those are all depressive symptoms. He denies suicidal ideation because if he did not, then we would need to escalate therapy. His symptoms are affecting his work. He has his past medical history, mild hypertension, well controlled, no history of ever taking psych meds, and no substance use disorder. So, pretty simple, straightforward case. And he's on losartan for his high blood pressure. So, what we used to do, and a lot of places we still can do this, like if someone needs to start an antidepressant, let's say it's an SSRI. So there's 5 SSRIs or so that we use regularly. But what we would ask the patient is, do you have any family members, a parent or a sibling that's taking any one of these meds? And then we would kind of use that as the clue of, well, if it works for them, then there's a good chance it will work for this patient, because it can take 4 to 6 weeks to find out if a medication is going to work for a patient. And that's kind of a long time, right? And so if we can get more data before we start, it helps us speed that process up, right? It can help with getting them better faster, right? So for this guy, let's say this is his sample. Well, I don't know how much about meds y'all know, but just so that you know, looking at these meds, all of my go-to drugs, except for one, for this guy, they're mostly red. And so um, I would have to think twice or 3 or 4 times before I chose one of those for him. This is not an automatic, like, oh, it's green, this is the right choice. But it's a tool to help guide therapy. And so it tells me that there's some that I need to avoid. These numbers here, they're little footnotes that tell you may need a higher dose, may need a lower dose, things like that. So for this patient, a lot of the ones that are green actually have some pretty crummy side effects. So like nortriptyline, we actually mostly use that for sleep. We don't even really use that for depression a lot. Trazodone, we only use for sleep, right? Duloxetine is usually more for anxiety and depression. So like this is not the do all and be all, but desvenlafaxine, I might use that. I like that one pretty well. But none of our typical SSRIs that are first line are green for him. So we would need to have a more conversation with him to talk about more of the components of his depression and how it's presenting, to personalize that medication for him. Another good thing about this particular product is it reports out his phenotype and his genotype, that I can then extrapolate that data. So, for example, 2C19, CYP2C19 is one of our CYP enzymes that metabolizes our drug, and clopidogrel, which is an antiplatelet that we give people after they've had a cardiac event or something like that. Well, if you are a 2C19 slow metabolizer, clopidogrel is a prodrug, which means it would never get metabolized to its active form, which means it wouldn't work. And so I would need to use the data that I got to say, well, that's not a good choice for him, even though that's what most people get. I would need to use a different one like ticagrelor. So I don't know how specific y'all want to get, but there's a lot of moving parts when it comes to personalizing medication for our patients. Okay, moving on. Next, so I
Oh,
talked about this already a little bit, so I'll just,
Jones, can I
yeah,
cut?
what's up?
We have a student
Please.
who has raised their hand because they want to ask you a question.
Yes, let me get to where, let me do this. Can you see me? Can I see you? I can see you.
Ma'am, there's something wrong with my video, so I can't show my face.
Yes, but Abisoye, what you got?
My question, ma'am, the previous slide,
Uh-huh.
the drug-gene interaction slide,
Yeah.
do you do similar things for drug-drug interactions and drug-food interactions, or do you just do that for drug-gene interactions? Do you get similar reports for drug-drug interactions and drug-food interactions and all the interactions? Do you get reports like that every time you're prescribing for drug, food, drug, or are you focused only on drug-gene interactions? Thank you.
Yeah, so there are resources for that, absolutely. So for drug-drug interactions, so we use Lexicomp. That's the tool that I like to use, which is from the same company that does UpToDate. If you're familiar, that it's from Walters Kluwer, and they have what's called an interaction check. And you can enter a patient's entire med list or any medication that you're considering and run an interaction check. And then it would tell you if it's a category X interaction. So there's X, A, B, C, and D. And so those tools are available. And a lot of times, like if you wanted to prescribe a medication to on a patient's chart and they already have certain meds in, most EHRs or health records have that sort of thing built in. So if you wanted to try to order something that interacted, it would pop up and say, there's a problem here with this other drug that they're taking. So you don't necessarily have to run a report for that. That's available. But usually an EHR will have that built in into the prescribing software. And then also on the pharmacy side, on the dispensing, there will be red flags. So if you had a patient, or for allergies is the same way. If you tried to order something that the patient was allergic to, it's going to be a red flag. And or if you've had an adverse effect, like side note, in your EHR, sometimes patients will report an adverse effect and think that it is an allergy, but it's really just a side effect of the drug. And so that's where our critical thinking comes in. So, like, someone might report, I'm allergic to hydrocodone because it makes me nauseous and it makes me itchy. Well, those are two side effects of hydrocodone. And so, if I really need you to have an opioid, and that was the problem, I can actually treat the side effects and still give you the drug that you need. So, there are definitely resources out there for that. Drug food, there are some. There's not a whole ton. The biggest drug food interactions are warfarin and food because that's based on vitamin K dependent clotting factors. And so for patients who are on warfarin, they do have to be very careful with their diet um, because most green foods will affect their how thin their blood is based on how the warfarin works. So, and those are the kind of things you learn as you go of, oh, this one could interacts with a lot of things. So you kind of learn that as you go. Genetically, we cannot test for drug food or drug disease interactions, as far as I know. Um, there are, yeah, but those are things that we kind of learn as we go. The CYP enzymes that they're produced in our liver pretty much that are our metabolizing enzymes are very genetically based. Um, and we learn which one of those are common in people. And so we definitely keep an eye on that. I hope that answered your question.
It does, but ma'am, the amount of testing you do, does it depend on the patient's insurance? So,
Oh,
is
that's a
it,
great question.
thank
That is a great question. So, for this particular product, I guess do I need to go back? Hang on, sorry. What screen are you seeing now?
No, we're on the patient case example
Oh,
screen.
good. Okay, good. Okay. So, this particular product, we Medicare, so any patient with Medicare, which means that they're 65 or older, Medicare will pay for that test, covers it completely. Arkansas Medicaid covers it. I don't know about other states, but Arkansas Medicaid does cover it. And then many commercial insurances do cover it as well because now they may have a copay for that. Medicare and Medicaid do not. But this particular company, if it's going to have a copay above a certain amount, they will call the patient first and they will not run that test without discussing it with them. And then they have payment plans. You will see more and more coverage for this type of thing because we're learning how valuable it is for our patients with just managing their treatment better, for sure.
Ma'am, how new is this? The drug-gene interaction screening. Is it a year, two
Hmm.
years old? Is it relatively old now?
I have been using this particular product for at least 3 years. So it is much more accessible than it was. And I would say I was probably one of the early adopters of this particular test. You can't, there, like any lab can technically do these tests, but they're $800, $900 and they tend to be pretty specific. So, most of them that way, they're just testing for your genetic components. They're not testing it against a drug. They would just tell you your genetic makeup, and then I would use that to interpret what drug. This particular product has gone through and kind of done that work for me. And they use the CPIC guidelines, which is who makes those. No, sorry, it's the who's in charge of the genetics. There's an organization that creates the guidelines for drug gene interactions, and when I think of it, I will tell you what that is.
Thank you,
Maybe
ma'am.
it's
Sorry to interrupt.
no, yeah, yeah, anytime, of course. Um,
Still
okay,
gonna butt in again.
do what?
I said I'm still butting in again. I got one more question
Go
for
for
you.
it. Go for it.
Although it's a big question, it might be multiple questions. We'll
Okay.
read it together. Do you know of any pharmacist, women's health practitioners, or research teams who are actively exploring GLP-1 medications for endometriosis or other gynecologic conditions like PCOS? Are any clinical pharmacists in women's health starting to pay more attention to this trend? Also, have you noticed an increase in different types of medications being used for menopause, such as new formulations of estrogen, progesterone, non-hormonal options, or updated dosing strategies?
Oh, we could talk for a long time about this. Yes. But you know what? I think I actually saw something today in my headlines about GLP-1 agonists and endometriosis. Because they're finding GLP-1 does a lot of stuff. And they're learning that part of what it's doing is it's actually decreasing inflammation just in the bodies of the patients, which is awesome. It's pretty wild. PCOS, absolutely. So one of the one of the ways PCOS manifests is in insulin resistance. So one of the medications that we give patients with PCOS, especially if they're dealing with weight gain and also fertility. So patients with PCOS sometimes struggle with infertility, and it's related to insulin resistance. And so if we can manage that insulin resistance, which the GLP-1 agonists also work on, I don't know if we have any results from those trials yet, but I do know it's absolutely being studied. And then menopause, it's yes. There's people. We're working really hard on menopause stuff. Yeah. So I don't. Well, so Premarin, Premarin is it's pregnant mare urine. It's estrogens. It's equine estrogens. So the word Premarin got its name from pregnant mare urine, which is where it was originally sourced. There's your fun drug fact for the day. But that's a estrogen, and that actually just went generic today. That has been a branded med for a really long time. I don't know about new or any novel dosage forms, but we do already have a lot. So we have oral, right? Like your birth control, your, combined oral contraceptives have estrogen and progesterone. We have patches, we have creams. There's a whole lot of conversation about vaginal estrogen in women who are getting older, postmenopausal. A lot of that tissue tends to break down, and you get frequent UTIs in older women. And they found that topical estrogen in that area resolves it. It's fascinating. So, yes, there's a lot out there and it's amazing. I would encourage you to keep an eye out. There is if you've heard of Mary Claire Haver, she's a OBGYN. She's all over Instagram and TikTok right now, but she's talking a lot about menopause right now. She's written a book called The New Menopause that is really fantastic. So I don't know how many of y'all are in that season right now, but you'll be treating people in that season. And so I encourage you to keep your eyes open because we're entering kind of a new day in menopause management for sure. They did just take the black box warning away from hormone replacement therapy. So you'll be prescribing a lot of this in family practice if you go into OBGYN. So keep your eyes open for that. Yeah. Oh, Kira, yes, I see.
Before
Go
I
ahead.
have that student, I did have someone ask a quick, brief little question. It says, have you found the lack of FDA sex-specific dosing information on drug labels to impact patient care?
What a fantastic question. You would most of the time, if there was a big difference, if they ran the clinical trial properly and they had a good balanced cohort, if there was a large difference in the results from a sex-based component, like if women responded this way and men responded this way, they try really hard to get a good balance, at least by the time something makes it into the guidelines. Um, but like for example, this isn't a sex-based thing, but like one of the really good hypertension papers that came out took place in China, which means every patient was Chinese. And so like they had really good data and where they were it was great. I cannot say 100% that that applies to my white and black patients because there are some differences. There are a couple of drugs that I can think of that, for example, Zolpidem or Ambien, which is a sleep medication, it is written into the dosing strategy that women should start on 5 milligrams and men should start on 10 milligrams. So that's one example. Um, Most of the time, um, I would say the dosing is based off what the clinical trials did. And they try to treat everybody the same, especially when they're trying to bring a drug to market, to try to have the most um, balanced cohort. So all of that sort of thing would have to come back from the subgroup analysis or something like that. For the most part, at least when I'm starting a patient on a medication, sex does not play into how I dose. Weight might. Um, but for starting out, but then I'm going to monitor and then I will adjust that dose based on the patient response. So, you're right. There's not a ton, but I don't know for sure how big of a deal that is when it comes right down to it. Yeah, we just got to keep an eye on our people. Yeah.
Do you want to continue doing questions or you want to hold questions to Q&A?
Let's do Q&A because I'm almost done with these slides and then we'll be done with slides.
I was thinking
Okay,
that.
cool. So I talked about slides. I mean, I talked about Harding. Um, I'm going to Nicaragua next month on a medical mission trip. We have one of our faculty members. He's actually a PhD and a pharmacist, and he's from Cameroon, and he helps run a HIV clinic in Cameroon, and he takes students there in the summer. And then I'm actually having a rotation in Italy next summer for the first time. I used to live over there, and we're going to spend 3 weeks over there talking about how healthcare is different over there, how being a healthcare professional is different, how is public health, what is lifestyle, things like that. So anyway, there's a little plug for Harding if you're interested in pharmacy. I can totally talk more about that later. And then this is my fun slide. So I've recently
Ah,
become an
yeah.
entrepreneur. Can you see that?
We cannot see that.
Okay, let me try that again. Let's see. Where
We
am I?
just see patient case.
Okay. Ha 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 ha. Here we go.
Oh, yeah.
Nope, nope, back
Perfect.
up, back up. Okay. So I have recently become an entrepreneur. Um, because I teach the course that introduces these top 300 drugs, it's a struggle, right? We have patients, or no, we have students that have worked in pharmacies for several years when they come to pharmacy school, and they kind of have an advantage. But it's hard. There's a lot of it's like having to memorize an encyclopedia, right? Because I have to be the encyclopedia. So what I have done is I invented something called RX decks, and it is 6 decks of traditional playing cards, just regular cards that you can play any card game with, poker or whatever. But every card is a different drug. And then it's got information about those drugs. And so if you want to get off your screens for a little bit, it's just a good analog learning tool. And then while I was in the process of getting those, they're in prototype mode right now. They'll be for sale probably the next month or two. And then while I was doing that, I got involved in a group that is really into AI. And so I am also really into AI. And so I learned about a a program, a website that will code for you. And so I went to the site and I've created RX Dex Solitaire. And so that's what this image is over here. It's the solitaire, just plain old regular internet solitaire that you can play with. You can choose which of the 6 decks you play with. And then when you click on this little button here on the bottom of the card, it opens up the image of the card that looks like this. And then there's a little plus sign next to it, and that opens up that has more drug data for studying. And then you can play in quiz mode. And if you play in quiz mode, then after every 2 moves, it asks you a multiple choice question about one of the drugs in that deck. So that is live, it's free. Feel free to go play that as much as you like. And then while I was in the process of creating that, I created Fluent with a PH. And so this is my, um, have you ever played Duolingo? Everybody uses Duolingo to learn a language. I was like, well, drugs are a language. Why don't I create my own? And so I'm still developing this sometimes a little bit, but I created Fluent. And this is live as well. I'm still working on building it out more. It's all also free. So you don't have to, but you can create an account. And it basically gives you, like, if it gives you the brand, you spell out the generic, or it gives you the generic, you spell out the brand. I have it to where it can pronounce the drugs for you and you can practice your pronunciation. One of the things I found with my students is because they have to spell the drugs right. Um, like sometimes the way they spell it wrong, I can tell that they're saying it wrong in their head. And so if we spent a little more time talking about the drugs, then it improves your knowledge and you can spell them better. So I'm actually building that out to make it more like Duolingo, where you can practice your mechanism of action, indication, side effects, etc. And it also has layered learning built in. So that part is coming where you can work on the things that you got wrong before. It remembers what you did and it takes you back through those. So that is what I do for fun. And I would love it if y'all want to try those out and then let me know what you think. Because it's really for any health science student, right? Everybody needs to know this stuff. And the more familiar you are, the better you are. And that is that. So, what questions do you have for me?
We had one more question that was, what are the most challenging aspects of your work?
Most challenging. I, hmm, most challenging is I love it all. So, and I love a challenge. I would say when I get a really long drug list, I like a really juicy drug list that I but they need it or they've always had it or they want it, right? Or they're like, well, I've been on this forever. Why should I stop? So, um, that can be challenging. Oh, another challenging thing is when the best medication for that patient is just unaffordable. There are definitely cost barriers for our patients. There are things that we can do. There are there are people out there that are trying. Um, Almost every drug manufacturer will have a patient assistance program for patients who qualify. So I work on paperwork for that for those patients. Finding cash pay for patients who are not insured. Um, yeah, getting access for my patients, that's probably the most challenging.
I had my question stolen.
Oh, no.
What would you say is the main difference between pharmacy and pharmacology? And would you consider yourself a pharmacologist as well as a pharmacist?
I, so to be a real pharmacologist is a PhD. So I would not be qualified as a pharmacologist. Now, in my College of Pharmacy, we have the pharmacy practice department, and then we have the pharmacy science department, and that's where the PhDs are. So we have pharmacologists on our faculty, but those are the people who study the drugs themselves. And then I, as a pharmacist, study pharmacotherapy. I would say that's kind of the pharmacology is the study of the drugs of like mechanism, structure, function, relationship, um, side effects, even dosing. Some of those can be pharmacology. But as a pharmacist, I'm more taking that information and applying it. So you might call it applied pharmacology, but most people who go into pharmacology are going to be in a lab. They're developing the drugs and stuff. So I don't think I'm qualified to be a pharmacologist. I just use their work in my work.
Your next question is, how do you stay updated on new medications and treatment guidelines?
I get about 40 emails every morning of what's up. And it's funny as I'm looking through and I'm seeing, just the subject line. I'm like, oh, I heard that yesterday. I heard that yesterday. I heard that yesterday. Um, so I want like my knowledge base is strong because I'm in academia, and so that's part of my job is to stay up to date. Um, I'm probably more up to date than a lot of clinicians because it's my job. That's part of my job. I don't have to hit the ground running seeing patients in the morning, right? So, I have the luxury of reading all my emails every morning. Um, there are like you can always check new guidelines. Anytime there's a new guideline that gets published, it's going to be in one of the emails I subscribe to. So like I subscribe to Medscape, I subscribe to New England Journal of Medicine, I subscribe to the AAFP, which is the Association of Family Practice. So things that apply to my practice site, I see. Um, yeah, and then all the pharmacy email. Anytime there's a new guideline, I'll get an email and I will go to that and I will read those. Um, yeah, it's the luxury for me that is my responsibility to be up on since I'm teaching it to other people. So that's how I do it. Which genes do the drug gene interactions look at? So it pretty much anything that we know has data related to a drug. It's not every one, but there are some usual suspects. So, like your CYP3A4, so your CYP453A4, almost 75% of all drugs are metabolized in some way by CYP3A4. So, we know that. Um, so there's things that we know, and then as new drugs come out, they're going to test them to that. I'm Googling real quick. I CPIC is what I want to say. guidelines. My internet's not good. It is CPIC, right? I'm sure it is. Anyway, there's an organization that is their thing, right? So the genes on the list would not increase. We already know pretty much all the genes. Um, it's whether or not a new drug interacts with it. And part of it is evidence, right? We might know academically that there should be a drug-drug interaction, but we have to have patient data. We need patient outcomes for then the the deciding factor to actually get put out. So we will get new guidelines and we'll get new recommendations from these organizations. So it's not necessarily about the new interactions. It's just enough evidence for them to put that into the guideline. Oh, let's see. Opportunities for advancement in your career and what level of education. So to become a pharmacist, you actually don't have to have a bachelor's first. Every school kind of has their list of prerequisites that they require for admission. There are a few pharmacy schools that are actually 0 to 6. So their undergrad and their pharmacy is all one thing straight through. Harding requires about 2 years of prereqs if you don't take any gen eds, but you won't have a degree. You won't have a bachelor's or a master's. You just graduate with that PharmD. You do have to have a PharmD. It is a doctorate degree, it's doctor of pharmacy. Um, and you have to have the PharmD, and then you have to pass the NAPLEX, which is our licensing exam, to get to that career. You can also, so you have to do, you can get board certified just like a physician would in a specialty if you specialize. So I am board certified in ambulatory care pharmacy, which requires an extra, you have to have worked in that area for a certain number of years. And then there's an exam, kind of just like you do with your different specialties. You can specialize in oncology, psychiatry, critical care, emergency medicine, ambulatory care. Um, there's 20. I think there's 20. Nuclear, pain management. You can specialize in pain management, pharmacy now. Um, so to get my job in academia, I had to complete a residency, but then I didn't get my board certification until after I was already in this role. So it depends, but that's my journey, and that's pretty standard. How much real world data shape your medication recommendations in women's health? Well, if we're going to get real personal, I am living in women's health as a woman. And so I'm invested in this. Uh, so absolutely real world data, right? That's how we get our patient specific. So we sure follow our guidelines, but like I don't know if y'all are keeping up with this, but the Women's Health Initiative was a huge study that came out in the 90s. And one of the conclusions that it drew was that hormone replacement therapy causes all sorts of cardiovascular disease and cancers. And so everybody got their hormone replacement taken away because out of caution. And then just this year, they went and looked back and said, wait a minute, these conclusions were flawed. And that has led to this resurgence of attention on women's health and hormone replacement. So that real world data, I mean, at least from an advocacy standpoint, for menopause, a lot of the patient real life experience shaped the advocacy, which led to those new conclusions, which have led to those new guidelines. So in that way, real world data, absolutely. And then we do a lot of hormone replacement therapy and we do customize it to our patients. We draw labs, we do estrogen, progesterone, testosterone, DHEA labs, and then customize their treatment on their levels and based on their presentation and their symptoms. Uh, let's see, Eva, you have your hand up.
Hello, can you hear me?
Yes.
Okay, hi. I have some questions for you. I'm not sure what's the limit of how many questions can I ask? How many questions can I ask? Sorry.
We got 10 minutes, so whatever.
Go say whatever you
Oh,
can
okay,
squash into
okay.
10 minutes.
Okay, I just want to like make sure others have the opportunity to ask questions too. Okay, so I just want to like introduce myself. Hi, my name is Eva. I'm actually a first year university student at BC in Canada. And
Uh-huh.
I'm a business student actually, but I'm planning to minor in biochemistry. And I do plan to become a pharmacy when I grow up. My dream is that once I become a pharmacist, once with some experience, I also want to run my own pharmacy. I think that's
Love it.
pretty fascinating. Yeah.
Love it.
Um, but the problem here for me is that I live in a small town and it's called Coquitlam. It's in the Tri-Cities at BC. And I was wondering what advice do you have for getting volunteer or entry level experience in a small town where pharmacies have like limited capacity? So like my town is like pretty small and like trying to like get to volunteer in a pharmacy is kind of difficult because there's many pharmacists that like says, oh, you need to have like a pharmacy degree to like, work in there, So it's kind of tough for me to
Mm-hmm.
do. And I was also wondering like what behaviors or qualities would stand out for someone before they even get interviewed to actually like have those opportunities out there
Yeah, well,
to
you've already done
volunteer.
the first thing. You showed up today. So good job. That's step one. Um, I'm not as familiar. I have a couple of friends who are pharmacists in Canada, but I don't know where specifically, and I'm not sure how your system works, but
Mhm.
there, if you wanted to, there are student, I guess you could subscribe. Look into like ASHP, which is American Society of Health System Pharmacists. You could maybe subscribe, to like their emails. Follow their socials for sure.
Okay.
APHA, which there may be a Canadian Pharmacy Association. Um, See if there's any organizations like that. If you have like in your not your state, your
In my
area.
province. Yeah.
Yeah, in your province, right? Is there a pharmacist association in your province? And
Mhm.
I don't know how spread out you are, but
Mhm. But
maybe
just like what happened, or it's just like, have you met any students who are like living in small towns at like USA and they're trying to get into volunteer for pharmacy and they're having a struggle with that? Like instead of just think about like the Canada, what about like the United States? How did those
mm,
students like did
mm.
it?
Well, so there's a lot of tiny towns in Arkansas, but there's a lot of pharmacies. So, um
Okay.
I would say so I'll tell you this, I did not work in a pharmacy before I went to pharmacy school.
Okay.
So that does not disclude you from pursuing pharmacy at all. So don't let that discourage you either. Especially pharmacy schools are going to know what opportunities there are, right? And so if you're from an area where that's not really an option, that's not they're not going to hold that against you, right? So but study on your those prereqs, right? Do well in your biochem, do well in those things, and those are very valuable as well. And then just view your undergrad studies through the lens of how will this help me be a pharmacist? And that's the kind of thing that goes into your letter of intent when you apply, right?
Mhm.
So that would be my recommendation is follow the pharmacy organizations on the socials, um, and see what they have going on, right? Like we have a pharmacy camp in the summer at Harding, and there may be places like maybe the schools, it may be far, but they may have like a week long thing that you could travel to. Um, Reach out, like if you know what school you want to go to, reach out to their admissions and ask them. They would love to hear from you, I promise.
Okay.
Yeah, be courageous when it comes to stuff like
Yes.
that. Yeah, don't be
Mhm.
scared, for sure.
Okay.
Yeah,
I will take that.
good, good.
Also my other question is that there was a time where you were like talking about your presentation and you were talking about patients, and I'm like really interested about patient care as well. but I
Mhm.
did some volunteering in a pharmacy before I went to university that time. And I was wondering, like, if there's any, like, if patients doesn't take their medications, for example, there's side effects or there's something they don't trust with, like, how do you deal with that like, that communication barrier?
It takes time. It helps if you can develop a relationship, which we don't always have time to do right on the other side of the counter. But knowing what you're talking about, right? So being able to show empathy to that patient, right? So like if a patient comes to me and they're like, I can't take this, it made me throw up, right? Well, not cool. So then it's going to be on me to see, is there an alternative? Because clearly that's not sustainable, right? Or this gave me such bad heartburn or something like that. Then the question comes, one, how much empathy can I show that patient to show them that I care and that I want them to feel better? The next is there an alternative to that medication that in my clinic I can pretty much make the changes myself? But if I'm in a community setting, how can I communicate that to the prescriber to let them know and maybe I can recommend something to them? Or is it something that the side effect can be managed? This is not ideal, but if the side effect can be managed with maybe it's the time of day that they take it. Maybe they should take it with food. Maybe there are some tips or tricks that I can help with. Like for example, a lot of liquid medicines for kids taste really bad, but we know some
I
tricks.
agree.
Yeah, so we have some tricks. Coffee
Hmm.
creamer, actually, like Coffee Make Coffee creamer really can help, or Hershey syrup. It's stuff like that. And when I can help with those small things like that, they're going to come to me with the bigger stuff. And so that's where the problem solving, the critical thinking, finding out what really is the problem with the medication um, can help for sure.
Hmm.
Hope that helps.
Okay.
Yeah.
Yeah. Okay. Last question.
Okay.
Um, I know that many pharmacies have different systems to like regulate medications or like to monitor and like do some inventory with medications. There's so many
Mhm.
types of like systems of them. Like I can't really explain, but there's many types of those like computer systems. So like how do you recognize which one is the computer system? If you know what I mean, like which one specifically? And also like is there any ways to learn more about the computer systems um before like working in a pharmacy? Like learning it online? Is there any like options or other opportunities out there?
So there's some big players in the EHR world, in the dispensing world. So like Epic is very popular. We use Meditech. A lot of it really is you just got to be doing it. Like when we switched, it's a huge learning curve, right? Because we kind of get in our habits. But what you're talking about is informatics. So if you want to learn more about that, it's called pharmacy informatics. You can actually do a residency in informatics, and those are the people that are working in the hospital on the back end, developing order sets, things like that. They're building out those programs to improve the workflow for the prescribers. So, yeah, it really is like we can't like in our school we don't teach a specific one because you're going to be at a different one when you get there anyway. But also, if you
Yeah.
once you get a job at a place, it is expected that there's a learning experience. Like
Hmm.
nobody goes into a job in pharmacy and they that you automatically know how to use their computer system because it's expected that it's new.
So you just learn with it
You
with
just learn it
them.
on the job.
Okay, okay. Thank
Yeah, it's
you.
built in. Yeah.
I think real world experience always helps so much. Um,
Yes.
I want to be mindful of your time, but did you
Hmm?
want to answer the last? There's three questions. They look pretty quick. Did
Sure.
you want to
Sure.
answer those or do
I
you want
would
to?
love to.
Okay. One of them is what skills do you think are most important for someone interested in entering this field, and how can you practice to develop these skills in high school to become successful in your field?
So if you can, it is a plus. to work a Saturday in a pharmacy. Like you don't have to have a whole lot of hours, but if you can see behind the curtain a little bit to see what it's like, it will help you know if it's for you. Um, I would say communication is important, right? The facts come once you get in pharmacy school, right? No one expects you to know how to be a pharmacist before you're a pharmacist. That's why you come to school. So learning is important then, but a curiosity, um, wanting to understand the how to kind of get to the, well, this does this. Well, why? Because this. Okay, well, why? Because this, because this. So like understanding every part of the pathway is important. And then, and just this is universal. Um, Whatever you're learning in whatever your class is, if you want to make sure you understand it, then you need to learn how to explain it to somebody else, right? Teach it, call your mom and say, hey, I just learned about the JAK-STAT pathway. It's a G protein coupled receptor. Doesn't matter what it is, but like learn how to explain it to somebody else, and then you understand it. So, and that's the kind of depth that we expect from a good pharmacist. It's more than memorization. It's really getting in and being able to explain it because we're communicators, right? And you who are becoming physicians, right? You have to be able to communicate your plan. Nobody can read your mind. And you have to be able to back up. You have to provide your rationale. And that comes from understanding the why. So that is a great skill. Um, how much time do I spend completing daily tasks? It depends on the day. Um, some days is a big patient day, and so it just it truly depends. I love my job because of the variety. That's one of the cool things about academia is I don't have 2 days that are the same. And I do have some agency over what my day looks like. Um, so it just depends. I mean, I work a full day, and then some days, sometimes I'm grading at night. I'm also very involved in all of the organizations, and that takes up time that I am choosing to give. Working on my business. So yeah, it all depends. Do certain traits your colleagues have impact your work positively? Sure, yes. Um, when they showing interest, that's another thing that you can do. It comes back to that curiosity. Um, People will want to know more about you when you ask more about them, right? People love to be known and they love to talk about themselves. And so, if you can provide them the opportunity to talk about themselves, then you've made a connection, um, which is always valuable. And that doesn't mean you have to be best friends with everybody, right? I'm not advocating for that necessarily because we don't have time for that. But just showing an interest in what somebody's got going on can go a long way. Um, have you ever had a bad experience with a drug-drug interaction or drug-food interaction or drug gene? Absolutely. Yes, happens all the time. Um, I would say most of them are not dangerous. Um, Most of the time, oh no, I can tell you a story. This just happened a few weeks ago at the hospital. I was on call at the hospital. It was a weekend, and I had come up there and they needed me to get a medication, neostigmine, which we don't carry in our pharmacy. I had to borrow it from another place and go get it. So neostigmine we use to kind of reverse anticholinergic side effects. So this guy in the hospital, he's intubated and he's full of poop, right? So super constipated. And so, and this is going to be kind of gross, but they gave him this medication and it worked. Let me just say that. It worked really well. He's an intubated patient, which means he's not getting up and going to the restroom, right? It really worked. Okay, well, as I'm looking at this patient's chart and I'm reading, I gave him what they wanted, but I looked and on his chart is a scopolamine patch, which you may be familiar with. You put it right here it's for seasickness or car sickness or motion sickness. It's an anticholinergic medication. Well, Anticholinergics work on your parasympathetic nervous system, right? So that's acetylcholine. It basically turns off your parasympathetic nervous system, which is your rest and digest. And so they had done this because he was having a lot of oral secretions, a lot of drool. And so they use that sometimes to dry up those secretions. Well, that worked, but it also completely stopped his gut. And so that was a medication for one thing that was causing this other problem. And so I was like, okay, yes, here's this medication, but you've got to take off that scopolamine patch because I'm sure that contributed to how we got here. So there's a real world example that has just happened in this past month that the doctor knew he needed it and he gave it. It had not occurred to him that particular side effect of that drug. Um, and so as soon as we recognized that, they took it off and it got okay. Any fatal experiences? Not in my experience. I have not had anything that extreme. There are some people that I work with that are really, really sick that, in the hospital that I'm at, people pass away. It's not really uncommon for that to happen. But in my experience, most of the time, it wasn't because of the medications. It was just because of the severity of their illness. So I don't have any stories about that.
I, I think that was the last of all the questions.
Okay.
I appreciate you staying so long.
Yeah, yeah,
Got
no
an extra
problem.
7 minutes out of you.
I'm
Um,
happy to do it.
Manosfi is my co-host, and she'll be concluding the session. So if anyone has any questions for us, you're welcome to stay till the end. Hopefully you don't have questions after our little wrap-up slides. But thank you so much, Dr. Jones. I just wanted to say that again as well.
Yes, I'm putting my LinkedIn in the chat if anybody wants to connect on LinkedIn.
We were all just talking about LinkedIn.
PharmD. There you go.
Hi, Dr. Jones. Thank you so
Hi.
much for your presentation again. It was really helpful, and I
Thank
really
you.
enjoyed listening to your experience. Yeah.
Thank you.
Okay, just to wrap up. Okay, so first of all, we can just start with reflecting on our session today. So I have three questions for you guys. The first one is, what was your favorite moment or example from today's session? What's one idea from today that you're most excited to explore next? And what's one key takeaway or idea that stood out to you the most? Feel free to answer on the PHS website or in the chat below. Other than this, we would love for you to share your insights on LinkedIn. And you can just tag us at prehealthshadowing.com. And your insights are really, really helpful and help us grow as a team together. Once again, if you are interested in being part of the pre-health shadowing team, you can register as a volunteer today, and volunteering is 100% remote, so you can do it from the comfort of your home, and we just love to have you on our team. And if you can, please consider donating. Even $1 helps because the foundation of PHS lies on the generous donations from you guys. And if you can't donate, that's fine too. You could also volunteer with us by dedicating your time. And don't forget to earn the digital certificate today for attending. You can just go to the PHS website and click on the session for Dr. Jones and take the assessment. From this, you will get a certificate that you could put on your resume just to make it more credible. And if you missed a part of our session today, you don't have to worry. You can just visit our YouTube channel of Pre-Health Shadowing and watch any of our sessions for free. Be sure to sign up for our newsletter and make sure that we're not in your spam, just so you can see our sessions every week and we can catch up. If you guys have any questions, feel free to stick around to ask the student team, and thank you so much for joining.